Welcome to The Cut, a series where I'm talking to experts about how small changes can have a big impact on patient outcomes after surgery.
Hi Kylie, good afternoon.
Good morning. How are you today?
Excellent, yeah.
That's wonderful.
We are very pleased we are in connection with you today. We were looking very much forward to it.
Oh, wonderful. We're really pleased that you're able to join us on this episode where we're going to talk all things orthopedic surgical wounds. So tell me, Philippe, what really drives your decision-making process when you're looking at post-operative incision management?
Post-operative incision management is something orthopedic surgeons were not very interested in because it was rather complicated when I started as being a resident. It's more than 20 years ago now. We as a resident didn't want to see the wounds because there were always some problems with the wounds and we only wanted to operate. I remember when I was in Antwerp doing my residency, the wound was checked on a daily basis. There was a question, should we stop the anticoagulants or not, because the wound was still draining. Minimal invasive techniques were not available at that time. And the dressings we've been using were just simple dressings with no absorption capacity. When I started here in Ghent, we tried to change a couple of things. We moved to minimal invasive surgery. The discharge protocol was different. And around 7 years ago, we moved now to advanced dressings. And advanced dressings have changed a lot. When we started here in Ghent, again, we checked the wound. It was the first thing we did on postoperative day 1, was removing the dressing, checking the wound, disinfecting the wound. And that was a routine that was being applied for more than, let's say 20, 30 years. And we have tried to change that, and we completely changed it now with the use of advanced dressings. So what is our protocol now? Our nurse applies the dressing in a sterile condition in the operating theater. The dressing is not removed because it has a very well absorption capacity. So if there is anything that's not correct, you can see it through the dressing without opening or removing the dressing. So with that experience now for 7 years, we've moved to a more extensive approach, which is leaving the dressing on for 14 days. Patients are discharged day 1 post-operatively. It was 3 days before COVID. Now we moved to 1 day, and we haven't seen any issues by handling that way.
That's a really interesting experience, and obviously it has taken some time to probably implement this into your clinical practice. Tell me, in terms of the dressing wear time, what was it that triggered an extended wear time? Because you look at a lot of clinical guidelines and protocols, I know here in Australia, but also internationally as well, the recommended wear time, 24, 48 hours. But this is an extended wear time of 14 days in some cases. Tell me a little bit more about how you came to that conclusion and what were the principles you were trying to drive at there in post-operative incision management?
The extensive wear time of an advanced dressing, we didn't have any experience, as you mentioned, is not routine, but we're using a digital follow-up tool for the majority of our patients that are using email, that are using smartphones, tablets, and patients, they use an application, so we follow them through a virtual care team on a daily basis. So patients do send pictures or photographs on a daily basis, or if there is any issue. So we were able to follow them during every day post-surgery in their home situation. So we got a really good view on how it evolved, if there were any issues or not, and that made us design our protocol now that is keeping the dressing on for 14 days until the staples or stitches are removed in the outpatient clinic.
It's a really interesting protocol. And I guess the question is, this is a bit of a chicken and egg scenario in that which came first, the advanced dressing and using that for an extended wear time, or the post-discharge surveillance. Tell me, which one happened first, or was it just serendipitous that is the way it happened in your clinical practice?
Actually, what came first, like the chicken and the egg? Well, we were lucky. Both came to us in the same period, in the same time. So we were lucky to have both at the same time, and we combined both to just to design our protocol. So in 2015, we developed a system where we could do a virtual digital follow-up of our patients, not only medically, so medication, rehabilitation, coaching, but also follow-up on the wound. And that's really important because that's what makes the patient nervous when they go home. If there is some issues, they cannot contact anyone, or we are difficult to contact. With that system, the patient is in constant communication, which is asynchronous, but it's constant communication with an escalation system, so the patient feels secure at all times. And we had to fight the nursing attitudes, which is a lot of nurses are still used to change the dressing on day one or to change it after 1 week. We make them confident with that, and now they follow our system and they feel very satisfied with it.
I think it's interesting to hear, as we all do, it's evidence-based practice, and some clinicians are less reluctant to change than others. Some need more evidence, and some are willing to take that chance and try and build the evidence themselves. It's interesting how you've put the patient at the centre here. So it's about following them up in a routine standard of care that's been happening in your clinic for quite a number of years. And this is the post-discharge surveillance program you're talking about, which we'll talk a little bit about very shortly. But I think from a patient's perspective, what is it that you think that the patient really needs when we're looking at rehabilitation after orthopaedic surgery, and what you really need out of an advanced dressing? Tell me a little bit more about that.
So what changes for the patient perception is when we tell the patient we're not going to change the dressing, we're not going to check it, we're not going to open it, the first thing a patient says, are you sure? Don't you need to check it, because I would feel more secure, more confident by doing so. Explain them, no, they are designed to keep them on. They are designed to mobilize immediately on the day itself of the surgery. They are able to move. It's a very elegant dressing. Besides, it's an advanced one, and it absorbs very well. It's very smooth, so the patient is not hindered in the way he or she can move. And last but not least, the patients are able to take a shower with it without any issues. And that's a question I get almost every time they go home on day one. Are you sure I'm able to take a shower with this, because I don't want to risk any issue or infection or issue with the wound and so on. And we've been so confident with it. They can shower, they can do whatever they want. They can put on very tight stockings and so on. And we haven't seen any issues so far. Even the borders of the dressing we use, they are made of a special material. So if it flips a little bit, it can be put again on the skin with a very, and it's really well fixed. So that makes them very, very confident, and us as surgeons and nurses as well. So I would never go back to what I've been using previously, because it changed our practice so tremendously.
I think that's the thing, isn't it? You know, you have that entrenched in clinical practice, and you've got the evidence, and you're using that evidence-based approach. It's also about the security that the patients are feeling with you and the confidence that they have in checking the dressing, or even knowing that they can pop into the shower or even go swimming if they need to for rehabilitation, which is an integral part of after orthopaedic procedure. But it's been great to talk to you today, Philippe, and I wish you all the best, and it's been a joy. Thank you for sharing your story.
Thank you very much, Kylie.